Hello, I'm Norman Swan. Welcome to this program on the Clinical Guideline for Diagnosis and Management of Early Rheumatoid Arthritis. Rheumatoid arthritis, as you well know, is a chronic, debilitating disease which may last a lifetime. Early diagnosis and management can limit structural damage of the joints and improve quality and length of life as well as other health outcomes. This program is the second of 4 programs on the new musculoskeletal guidelines. The clinical guidelines for general practitioners and other primary healthcare professionals have been developed by the Royal Australian College of General Practitioners and approved by the National Health and Medical Research Council. This program will cover the diagnosis of rheumatoid arthritis and discuss the recommended interventions for early RA in the Australian primary healthcare setting. As always, you'll find a useful number of resources available on the Rural Health Education Foundation's website, rhef.com.au. I'll introduce our panel to you. John Bennett is a general practitioner at the University Health Service at the University of Queensland and was a member of the College of GPs working group for the guideline. Welcome, John.
Thank you, Norman. Thank you.
Lynn March is a rheumatologist at Royal North Shore Hospital in the University of Sydney. Welcome, Lynn.
Thanks, Norman.
Lynn was also a member of the guideline working group. Christine Retallick is a community health nurse in rheumatology working in the Albany Rheumatology Clinic in Western Australia. Welcome, Christine.
Thank you.
And a pretty unique species, the community rheumatology nurse to Western Australia, isn't it?
It is. It doesn't happen anywhere else in Australia.
But perhaps we'll find out it should.
Yes.
Let's hope. And last and certainly not least is Louise Sharp, who's Associate Professor and Director of Clinical Research in the School of Psychology at the University of Sydney. Welcome, Louise. And Louise has a strong interest in rheumatoid arthritis and similar diseases. Well, to start, let's go and hear from 4 women from Western Australia, Liz, Anne, Terry and Jill, about their experiences of having early RA.
1983 was quite a stressful year for me, but I felt that I was a bit overweight and I was doing an exercise program at home. And each morning I would wake up very sore and stiff and think, oh, how unfit I am. So I'd push myself a little harder until I was really unable to sleep or unable to function very well at all.
I couldn't get out of bed a lot of the times. I was overwhelming fatigue. Just really felt like I had a bad flu all the time. Like my body felt like I had an extreme, like the worst flu you've ever had.
It was getting worse and worse. I was finding it hard to get down to the bus stop, to get to work, to do those sorts of things.
Yeah, definitely was depressed. Really didn't want to do much. Just sort of wanted to hide away from everyone. I wasn't really my normal self at all, no.
I was afraid and, pretty unhappy.
It was doing my head in. I was saying to my daughter, to my friends, I think I'm going nuts. I don't know what's wrong with me.
I was shattered. I went out and bought some clothes that I didn't want and didn't need.
Other people around often would think, oh God, there's Liz whinging again. She's got the hypochondriac hat on, and one of the problems with an early rheumatoid arthritis is the pain moves from joint to joint. So one day it might be in a wrist, another day in an ankle, and another day in an elbow, and then a shoulder. So I began to feel a bit hypochondriac.
4 stories of early rheumatoid arthritis from Western Australia. I'm not sure that today we're going to find that there's level 1 evidence for retail therapy for rheumatoid arthritis, as one of our respondents there was telling us. But John, how typical are those stories?
Very, very typical. It's interesting how each one of them, I think, or without fail, had a very strong psychological element of a suffering that went beyond the physical.
We weren't hearing much about joint problems, Lynn.
No, we weren't at all. The patients don't tell you that their CRP's raised and their joints are swollen. They tell you all the things that matter to them, the fatigue and just the overwhelming systemic effect of the disease. And I think that's the cytokines of inflammation, but they don't tell you those words. Yeah.
How dominant is that psychological element, Louise?
Well, certainly when people develop rheumatoid arthritis, there's good evidence that about 1 in 5 at any one time will be depressed of clinical magnitude. And certainly we found in some of our early research looking at early arthritis that actually increases in the early phase of the illness. So that if you don't give people help and support and help to manage it, that, the symptoms are so all-encompassing and systemic as well as the pain, which really does get people down. And then, as the stories themselves were saying, starts to create a a vicious cycle where they then find it very difficult to do the things that they need to do to actually manage the illness better.
And is the treatment of the depression the treatment of the illness or the treatment of the depression?
Well, if the depression in this instance is as a response to the illness, then actually if you help people to learn to take some control over their illness and to manage it better, what you find is that the symptoms of the depression do actually lift. And you can use some very good strategies that have been used in the treatment of depression outside of ill health, but focus it towards the illness, and actually the outcomes can be very good.
So Christine, we're going to be talking about early detection and quite active management of somebody with early rheumatoid arthritis. For success, how important is it to actually, I mean, it sounds like a Dorothy Dixer, but and it's easy to say, well, very important, we say the whole patient, but really how important is it?
It is extremely important to see the whole patient and not just the swollen joints. If you can actually help people to do well with their emotional, the emotional side of their condition, as well as functional stuff, then they do so much better.
And what do people tell you with the rheumatoid that bothers them the most? Because they've been diagnosed with a chronic illness, quite a serious one in fact.
There's probably two things that they worry about, and one is fatigue, the overwhelming fatigue that they experience, and the other one is the introduction of drugs that they have never seen the like of before. And it's really important to discuss the drugs with them so that they do understand that they need to take them and how they work, and that they do need to have follow-up blood tests and so on to monitor how they're going.
How important, what's the evidence, Lynn, that early diagnosis and intervention makes a difference?
There's overwhelming evidence now that it's the right thing to do. 10 years ago we thought it was the right thing to do. Now we really know it's the right thing to do in terms of improving outcomes, improving quality of life, preventing the joint damage, and even improving mortality or lengthening life. Because severe rheumatoid reduces life expectancy, and with the drugs...
From coronary heart disease as much as anything?
Yes, yeah. And particularly in males, probably lowers life expectancy by at least 5 years. So treatment early helps improve that.
Now, I've heard John, rheumatologists, say that the flail joints, the ulnar deviation, those horrible hands, is a thing of the past. You don't see that so much anymore, apart from people who might be really elderly who've had rheumatoid for a long time. But for modern treatment, you don't see that anymore. Is that your experience?
Well, I guess both are true. I mean, the newer drugs certainly offer much greater promise than we've seen before. So hopefully they will become much more a thing of the past.
What figures are we seeing here, Lynn? I mean, how common is it? My understanding is that it's commoner than people think.
Yes, yeah. I mean, well, 2 to 3% of Australians in national health surveys think they have rheumatoid arthritis. Maybe it's a bit less than that. So at least 1% of the population, though, has rheumatoid arthritis. And in terms of new cases, even though the incidence is declining around the world, probably at least 1,000 new cases in Australia based on our population every year will have a range of severity of rheumatoid arthritis, but at least 1,000 new cases every year.
And most GPs will have a patient in their practice?
Yes, most GPs will come across it. I guess not every day, as we've talked about.
But you were saying earlier that it's commoner on an incidence basis than type 1 diabetes?
Yes. It's more common than that, and more common than multiple sclerosis, more common than other things that attract a lot more attention at times. And I think rheumatoid arthritis has been something, well, everyone gets it, we can't do anything about it. But clearly that's not the case with rheumatoid arthritis.
Now, I've heard some say that the window of opportunity here is 6 weeks.
That's what we're recommending, and the evidence, the earlier you get on top of it, the earlier you diagnose it, the earlier you treat it, the better the drugs work. If you wait 6 months, you can still use the same drugs. You're still highly likely to get a response, but it won't be as good, and you might have already had erosions by that time and joint damage.
That's a pretty tight rope to put GPs on for diagnosis, John.
It's difficult, and as we're saying, it is an uncommon disorder, but hopefully there's an opportunity to pick it up early and to make a difference, to improve people's lives.
Christine, you've done some work with colleagues on the incidence in Indigenous communities, because this is a condition that people say is genetic, related to HLA type. How common is it in Indigenous communities?
When I was looking at the research, the research actually showed that there were, in 2001 I think it was, there were only 15 cases of rheumatoid arthritis in the Indigenous population in far north Queensland. And I'm talking to a colleague who actually visits the Kimberley as a rheumatologist. He has no cases of rheumatoid arthritis. And the research actually showed that the majority of cases of rheumatoid arthritis in the Indigenous population where parentage was mixed, so of Caucasian or another ethnic group that carries the RA with them.
So what do we know about the causation, Lynn?
There's definitely a genetic element. There's no single gene that's been identified, but there's strong family history, strong in dizygotic and monozygotic twins. So definitely underlying genetics, but something else triggers it, an environmental trigger, but often you don't find the trigger. Smoking increases risk, probably through its ability to generate some antibodies to citrulated peptide, but smoking is a risk factor. Morbid obesity is a risk factor.
Vitamin D levels?
Vitamin D levels, some association in terms of inflammation. There's some interesting research going on.
But it's commoner in Tasmania than it is in Sydney.
Yeah. Hasn't been as strongly linked as some of the other conditions like multiple sclerosis, but there's we're looking into some treatments for that. Oral contraceptive pill might be protective.
Pregnancy?
Pregnancy, usually the symptoms of rheumatoid abate during pregnancy, so that the pregnancy-related hormones have an anti-inflammatory effect. No evidence that pregnancy sort of increases or decreases your risk though. Blood transfusions might be a risk. Occasionally the immune system's triggered by vaccinations and immunisations, but
so there might be a viral etiology, but
possibly,
various viruses.
but never been a single infective agent found though.
So you find it early.
Mm-hmm.
What's your aim with treatment?
Well, the aim of the rheumatologist or the aim of the clinician is to put the disease into remission.
What's that?
Remission is when you've got the disease, it's gone away, but you still need drugs. It's very rare that we cure the disease.
So when people talk about drug-free remission, those might not be people with rheumatoid arthritis.
Well, a small percentage can go into drug-free remission, but our knowledge of the disease is that it always tends to come back, even when you've got people under very good control. So remission is ESR CRP is 0, or zero, normal.
CRP
normal
less
range.
than 1.
CRP less than 1, ESR less than 5. The joint count, swollen tender joints, 0. So if you've got some joint swelling, you've still got some rheumatoid disease. And to the patient though, that means nothing. Well, it means something, but it means their pain's gone, but it also means usually that their fatigue is under control. So again, the patient's looking for improved quality of life and energy levels back and that sort of thing. But as a doctor, we're looking to mainly see no erosions, no joint damage. But in order to get that, you really have to have 0 to a very low joint count and normal inflammatory markers.
And there's all this debate about these new biologicals, people walk in the door saying, you know, can I have my etanercept or my rituximab or whatever is the latest one being advertised in the United States. What is the role of these biological agents in the treatment?
They're very powerful and very useful agents. In Australia, we can have them for people who still have very severely active disease after they've failed 2 or 3 other disease-modifying agents, and still have active disease in that. But they have an important role, but they're not without some potential for side effects as well. So they need to be used appropriately. Yeah.
So what are John, just give us a sense, we'll come to some case studies in a moment, but give us a sense of what this new guideline tells you to do in terms of diagnosis, because we are asking the GP to make the diagnosis before referral, aren't we?
Yes.
As much as possible.
Yep.
So what's the algorithm, if you like?
It falls into basic clinical principles that one would take a history, look for features that would be suggestive of arthritis. So the classical symmetrical small joint disease, fatigue, stiffness that persists for some hour or more into the morning on wakening, and then follow that up with certain blood tests, ESR, CRP as a marker of inflammation, the time-honoured rheumatoid factor and the anti-CCP. if you were suspecting rheumatoid, they would be the mix of tests you'd go for in a directed way.
What's this anti-CCP, Lynn?
Before we get to that, though, I think we don't necessarily need the GP to make the diagnosis. And if they're sitting waiting, sometimes if you wait until you've got a definite diagnosis of rheumatoid arthritis, it's too late. Because you've already got the rheumatoid factor and you might already have erosions, already have joint damage. So I think the key message that comes out of the guidelines and early referral, even if those tests are negative, if someone's still got persistent swelling or symptoms in their joints, refer on or seek additional advice, because the joints should not persist in being swollen beyond sort of 6 to 8 weeks, because there's potential for joint damage.
So regardless of what the biochemistry shows?
Yes, try to work up the diagnosis, but and clearly that saves time for the patient and for all the treating doctors. But don't wait till you're totally convinced it's rheumatoid, because it's often too late.
But Christine, GPs watching this from rural and regional Australia, and we'll find out in a moment just what proportion of our audience is that, are those, they'd say, look, it can take me a year to get somebody into a rheumatologist. What do they do?
They refer, and in our particular instance, I can actually triage the referrals, so that people who have a referral that's indicating an inflammatory condition or where I'm a bit suspicious, I can follow those people up. I can talk to their GP and make sure that they get in to be seen.
So the GP
much
knows
earlier.
that there's a clinic in town that they can
Yes,
go to,
they do.
run
Yes,
by
they
an
do.
expert nurse?
Yes.
How often does that happen anywhere else in Australia, Lynn?
Yeah, not many other states or any other states have that luxury, and I guess that it is a problem for GPs at times to get access to rheumatology services. But certainly the Australian Rheumatology Association has a website. The public can look and see where rheumatologists are. GPs can look. Not every rheumatologist is on that, but if someone's in an area where they feel they can't get access to a rheumatologist, they should email, contact or call the Australian Rheumatology Association Secretariat, and we'll get them in touch with someone.
So Lynn, those women who said, you know, they had fatigue and they weren't talking about the joints, perhaps the last lady speaking, when the GP if the GP was to take a full, not just take this as fatigue, but to actually ask the next questions, because they might be thinking of gluten enteropathy or thyroid, or might be a whole lot of things or that they might be thinking of, but they do ask the questions about joints. In what proportion of cases, when it is rheumatoid, are they going to get a joint story?
A high percentage. The majority will have some joint symptoms. They might be coming and going, like the last lady said. It's sort of that palindromic rheumatism, where it's all sore and painful, and by the time they get to see the doctor, it's actually gone. That's a very common scenario when rheumatoid's first starting. And the synovitis can be very subtle. It might just be, and particularly wrists and shoulders, you don't even always see it, but so it's sort of based on that morning stiffness and looking for inflammatory markers, doing some blood tests to sort of see if there's an associated inflammation. And yes, of course, you'll occasionally see people who don't have much in the way of joint swelling, have normal inflammatory markers, but sort of go on to sort of damage their joints. But they are the minority. The majority will have some joint symptoms.
So just this anti-CCP is just
coming back to that, yes. So it's antibodies to citrullinated peptide, which is part of the cell nucleus, one of the peptides. It's probably just as sensitive as rheumatoid factor. So if your rheumatoid factor is positive, the CCP doesn't really help you make an additional diagnosis if you've got the clinical picture, but it is more specific. So rheumatoid factor can be positive in other things, chronic infection, just part of an ageing phenomenon, whereas CCP at this stage appears to be quite specific for rheumatoid. But it's also a poorer prognostic marker, and particularly if you actually have rheumatoid factor positive and anti-CCP positive, looking in early onset arthritis, sometimes up to about 30-40% of an early polyarthritis will be gone in 12 months. But if you've got both rheumatoid factor positive and CCP positive, your chances of having erosive, damaging rheumatoid arthritis at 2 years are very high. It's sort of like a 90% predictive value that you will have an erosive disease. So they're quite strong prognostic markers. Very useful to help people realise in part of that education, sort of knowing why do I have to take all these drugs. If you can show them some of that prognostic marker stuff, then it means a little bit more to them, that it is worth the trade-off. It's of the potential for side effects and the things that they do worry about with their drugs. It's worth taking that trade-off.
John, what's the role of the GP in all this? We've alluded to this, that we're expecting the GP to refer promptly, maybe do some tests first, so they're sure. What else? Because if you take type 1 diabetes as an example, most GPs run for the hills. And if you don't run for the hills, the local children's hospital takes the child away from you.
Oh, they like doing that. Look, I think it would fall into, just again to consider the diagnosis. It's uncommon, but if people, as Lynn's been saying, have some sort of persistent joint swelling and other symptoms that go with that, with or without the test being positive or not, you need to consider that diagnosis. In the sort of longer term, I guess, then there's that role for GPs as they do in so many chronic diseases, just to help maintain the patient through that, help to coordinate care with the various health professionals who'd be involved.
Lynn, some people would argue that remission is no more erosions on in your joints. So it's, in addition to what you've just said, you stop the disease in the joints dead. Is that what you aim for in your remission?
Yeah, that's the ideal, that you see no more damage in the joints. X-ray, I guess, is the crudest way to see erosions. I think as time progresses and and maybe MRI becomes cheaper and Doppler ultrasound, there are a number of different, that are at the moment, they're research techniques, but there are a number of different techniques to show very early changes in the joints, and also you'd want to see that those changes were switched off, yes, and that's remission. Because people who appear to be in clinical remission with that scenario I suggested, with normal inflammatory markers and normal looking joints on examination, actually can still have ongoing inflammation.
How early do you think somebody, I mean, we're talking about rural Australia here, where it's not easy to get allied health professionals, but how early in an ideal world would someone like you, Louise, be brought in?
Well, certainly, I mean, our research suggests that the earlier that you intervene, the better for people. Because I think what's really important is the time when people are least likely to do what's best for their own management is actually early on, when they're just adjusting to illness. And they're just adjusting to the idea that they have an illness. And if you don't believe that you have an illness, then you're not actually going to do the things that will actually help you to manage that illness. And so part of needing to accept that you need to take medication, that you need to actually develop a balance between rest and exercise and listen to your body, that you need to have a optimistic but realistic attitude about the future, is really helpful in terms of how you manage it. And in my own studies, one of the things that we've shown is if you can get in, certainly we found in the first 2 years of illness, that you can actually affect long-term outcomes. So 5 years later, you can actually show that people are needing to use fewer healthcare resources because they have managed their illness well enough in the shorter term, if you like, that they actually become less disabled over time.
And that's just doing evidence-based therapy as a psychologist, cognitive behavioural therapy or interpersonal.
That's exactly right, and helping people to really try to change what they do to respond to the illness, if you like, so that they don't become overactive on inflamed joints, or at the same time don't sort of respond to the stiffness by inactivity, but foster that balance between rest and exercise, and try and teach people skills to maintain that kind of optimistic attitude that protects them against depression.
Let's try a case study. Let's meet Lily, who comes in to see John. She's 32 years old. She comes into the surgery with stiffness of both her hands, wrists and shoulder joints, and when John examines them, they're slightly swollen, tender and painful. It's developed over the last few months, and tends to be worse in the morning, and she's a smoker, and she's got 2 kids, both quite young, and she's pretty tired, especially in the afternoon, which she puts down to all the running around with her children. There's lots of tired mums out there.
There are indeed.
It's winter, there's a lot of people out there with sore, aching joints.
Yeah. I guess it's part of the challenge of that soup you see in general practice, of trying to pick out the sort of bits that you should really be considering. It's a difficult problem. This one's, highly suggestive of it because of the features. Small joints are involved, more than 3 areas, there's a symmetry to it, morning stiffness, fatigue, lots of markers there that you'd at least should be thinking that this woman has, you know, the potential for some more severe forms of arthritis.
So if you're following the guideline, what do you do as the GP?
Well, as has been set out there, we've assumed with the examiner, we've confirmed that there's some joint swelling in those areas as listed. I mean, I think with that presentation of that time, it would be reasonable to do the test that we'd discussed before. That would be a ESR CRP looking for evidence of inflammation and the time-honoured rheumatoid factor and an anti-CCP.
What are you going to do if it's negative? They're all negative.
I suppose it would be reasonable to institute some therapy. I mean, I suppose you'd be doing that in either sense because she's clearly in pain. It's clearly influencing her ability to function as a mother.
She tells you that she's been taking Panadol and it doesn't make any difference.
Okay. You could then, I mean, because she's younger, it'd be certainly worth trying some anti-inflammatories to see if that would help. You know, suggest some ibuprofen if there weren't any other reasons for her not to take that, and see what that brought her in the short term. But again, that would be, you know, even just while you're waiting for the test, you could do the two things concurrently. See if you could bring some relief while you got some further indications.
But the clear message here is you don't hang around.
No.
You bring her back soon. What,
Yeah.
after 2 weeks or something?
I guess it would depend upon how she was functioning. See, she's had the symptoms
So we're talking
for
about
a
a
while
6-week
from our
window
notes.
of opportunity here.
Yeah.
So you can't wait for a month.
Oh no, because there are several. Well, it's the scenario says a few months, I think, is there. So yeah, no, you would need to get her back. It would depend what her ESR CRP was for me in that sense, as to how much sort of demonstrable evidence there was of inflammation. If that was up, you'd certainly want to get her to see somebody much more rapidly.
Are non-steroidals liable to have an effect if it's rheumatoid, Lynn?
They'll help in early rheumatoid and mild disease for the early symptom control. They don't have any impact on the actual disease control and slowing erosion, slowing the disease. But I think the alarm bells here with Lilia that you could quite easily dismiss her because it's a few months and a brand new baby and tired and those sorts of things. But the alarm bells here that she's got joint swelling, and it's only slight, but it is only always slight in early rheumatoid. So I think the fact that that's persisted, you can't really put that down to tiredness. Yes, there might be some hormonal changes and all of that sort of thing. She might be still breastfeeding. You'd need to weigh that into your decision making for her. She might be thinking of more babies soon, so that also influences what you might do. But but non-steroidals could help her a little bit. But again, you wouldn't really want to be waiting around too long. Perhaps you'd start the non-steroidals, start the tests, and organise the referral. And sure, if she's better by the time she's seeing the rheumatologist, she can cancel the appointment. But the other thing I'd try with her would be some high-dose omega-3 oil as well, either as fish oil or flaxseed oil, because although that takes a little while, that can be a good natural anti-inflammatory, work almost as well as the non-steroidal
And when we talk
drugs.
about high dose, we're talking about 15 mils of the oil.
Depending on which oil that you use, there's a number of different brands now. There's either 15 mils, there's a one that you can take 5 mils, there's a number of different brands, or about sort of 10 to 12 capsules. But I think the important thing is to sort of to look up the actual dosage of the DHA and EPA of the omega-3.
So what's the equivalent dose that you're looking for?
So you need probably 3 to 4 grams of actual DHA or EPA
a day.
A day, which is quite a lot of omega-3, and does take, I guess, 3 to 4 weeks at least to have its full anti-inflammatory effect.
But as a stopgap measure, if you're all negative. So how often does a woman like this turn up with negative tests, and do they become positive over time?
Well, rheumatoid factor and CCP only have about an 80% sensitivity, so there are up to 20% of people who have classic rheumatoid arthritis, including damaging and eroding their joints, who are never positive. But it's a very common scenario that they're negative in the first instance. So in someone like Lily, very common that they would be negative. They would become positive over the next 12 months or so. Unusual for the CRP and ESR to be totally normal, very
Right.
unusual. But you occasionally see just very low levels, but people still are destroying their joints. So I think it gets back again to if you see some joint swelling, no matter how slight, if it's persisting, then seek referral to confirm that.
And if a rheumatologist isn't available, I mean,
yeah.
I was talking to some rheumatologists the other day, and a rheumatologist in North Queensland said he's got a 2-year wait to be seen.
I think yes, they might have 2-year wait, but I think all rheumatologists would, if the patient's been worked up appropriately and they get the call from the GP, all rheumatologists will respond to that in some way. Or if you've got the luxury of the Western Australian situation, the community nurse will respond. Most rheumatologists would welcome the call from the GP that said, what tests will I do? What will I do while they're waiting to see you? I've got this patient.
So, John, what alternatives should you be looking for as well? What's the differential diagnosis here that you should be eliminating?
I suppose it would be, a younger female, again, it would be reasonable if you're going to be ordering a set of tests or ANA, and if that was positive, they'd do the more specific things looking for lupus. I guess with that number of joints, you wouldn't be thinking of things like gout, and she's in the sort of wrong age and gender. You'd be...
Does joint aspiration have any role if she's got a swollen knee?
Yeah, you could. You'd certainly have a look. I would have to sort of depend upon ringing a sort of rheumatological colleague to see how to interpret the result, but it could certainly be of assistance.
Lynn?
Sure. If there's a swollen joint, a single sort of reasonably swollen joint, it's always worth aspirating because it might be infected. There might be crystals. There's no definitive diagnosis, but sometimes you actually find the rheumatoid factor in the synovial fluid, and you don't find it in the blood yet. So early rheumatoid, that can be positive. The white cell count gives you some clues, and it can be therapeutic at the same time.
Sometimes the rheumatologists will just say get going on some DMARDs, and just take us through what the non-biological, the standard DMARDs are, because they can be remarkably effective, can they not?
They certainly can. They certainly can. I guess the gold standard, and in fact what all the biologic agents have been compared to, is methotrexate. So we really put that up there as the gold standard, but not every patient wants to take methotrexate.
But it's less toxic than a non-steroidal, isn't it?
It is less toxic, but one does have to limit alcohol intake, and you have to be monitored. Not everyone is in a position to be monitored or want to be monitored in terms of their monitoring blood tests. Not everyone wants to maintain healthy alcohol intake or no alcohol intake. So some people want to become pregnant. So there's a number of people that you don't prescribe methotrexate to, and also now you might just use methotrexate as a monotherapy, as a single therapy, but there's a reasonable body of evidence that if you have more aggressive disease, that you're better off with a combination of therapies that work in different ways.
Like hydroxychloroquine, and
slazopirin, are the main three that you would use first up. There are other ones available too.
And I'm told them used in the right dose judiciously gives you as good a result as adding a biological in terms of getting remission?
In terms of getting clinical remission and getting early symptom control, yes, that's correct. But if they aren't working within a sort of 3 to 6 months, according to our guidelines, then you could get onto a biologic. And if you look very closely at what's happening at the joint level and the synovial level and erosion level, the rate of remission is probably greater if you can add in a biologic early as well. But by and large, the majority of people get very good response to early and pretty aggressive therapy, like treating to a target, like really treating to get their CRP and ESR in the normal range, get their joint count right down low. And we've all sort of been brought up with the, first do no harm. And of course all these drugs have some side effects. There's no such thing as a side effect free drug. So there's that trade-off as well, that getting that right. And and the patients don't always want the side effects of the drugs too, because they see it as arthritis and perhaps something that's not going to kill them. But I think the message with rheumatoid arthritis is that it's about getting in early.
And John, in terms of what might kill you, it's like diabetes. It's a heart attack that's going to kill you, or a stroke from the inflammation. At what point do the guidelines tell you to institute quite aggressive coronary risk factor reduction
My take on that is you'd actually see them in a high-risk group, and you might, in an equivalent sense, I suppose, treat them like they had diabetes. You could be quite aggressive wanting to get their total cholesterol.
And with Lisa, a 32-year-old woman with 2 children, would she fit that?
Well, hopefully not. Hopefully she doesn't have other factors, except she's a smoker. You'd obviously be strongly into her about, this is a very good time to give up for a whole range of reasons.
And does that help the symptoms? Is there evidence for that?
Not sure there, I think.
I don't think there's any evidence that it helps the symptoms, but people with rheumatoid arthritis get bad lung disease, get bronchiectasis. If they smoke as well as have their rheumatoid arthritis, they are at higher risk. So she should stop smoking for lots of reasons, but the cardiovascular risk factor monitoring is critically important. All the traditional risk factors are important, but maintaining a normal CRP is probably important for the cardiovascular risk long term as well.
So Christine, how important is multidisciplinary care, particularly in a country town, for somebody with rheumatoid arthritis? So
Extremely important. If cardiovascular disease and the like are all slightly higher percentage in country and rural areas, and so if we've got rheumatoid arthritis added to that picture as well, people then are at high risk. And so even in between when we get a referral, I've seen the patient and they see the rheumatologist, if they're a smoker or they're overweight, we can actually do something about that or start to do something about that. They may need some occupational therapy to help them with daily living activities.
And psychologically, Louise, what would you be doing for Lisa?
Well, I think the first thing that you'd be wanting to really talk to her about is about what the long-term prognosis is, to try and help her to not, again, be concerned inappropriately about the future, but to take the illness seriously enough that she's motivated really to be trying to get that balance between rest and exercise that we talked about, even at such a demanding time in her life where, she perhaps has so much going on, that the need to prioritise her health in these early stages is really, really crucial, I think, for these patients.
And if she's breastfeeding, how does that affect the therapy?
Well, it can affect it quite significantly because all of the disease-modifying agents can get into the breast milk, and so she would probably want to delay that or trade off again, wait a little while, or even consider stopping breastfeeding if her disease is active enough. The anti-inflammatories and steroids some will get into the breast milk, so it's a matter of timing it for using the shortest acting anti-inflammatory and timing in terms of when you breastfeed.
Listening to rheumatologists talking about rheumatoid arthritis, they say prednisone is out, the occasional intra-articular injection, but they don't want people, they take it as a matter of pride that they don't have patients, almost zero prescribing of prednisone. And
they might all say that.
and almost zero non-steroidals as well.
Yeah. It's certainly our aim to have people's disease controlled on disease-modifying agents alone. But if you look at most rheumatoid patients, long-standing patients, a vast majority, 40–50%, will be on some prednisone because it works so well. And early regimens that treat to target with the combination therapies all have some component of the corticosteroid, either as intra-articular, multiple intra-articular, intramuscular, or orally, or intravenously. So steroids work very, very well. They probably are also disease-modifying agents in terms of reducing erosions.
But you get hooked on them.
But yes, it's very hard to get back off it. So if they're very effective for controlling symptoms, and if there is some sort of delay, even though most rheumatologists do not like the steroids to be started before they've seen the patient, sometimes you just have to. But if you do start steroids, you really need to have a withdrawal plan as well to see, wow, is it gone yet or what's happening?
Because they can be life-shortening in their own right.
They certainly can. And if you look at longevity now, that's the trade-off. So you might get disease modification early, but the trade-off is that you get atherosclerosis and coronary heart disease and risk factors longer term.
So the surprise is that something like methotrexate isn't as toxic as you think.
That's right. It's also got its potential for side effects and needs to be monitored, but it's safer than non-steroidal.
The monitoring is white cell count, and somebody told me that a reduced white cell count is actually good news. It shows it's working.
That's right. If your lymphocyte count's down a bit, then it means it's having some modification on the immune system. Yeah.
Let's go to our third case study. This is a 65-year-old woman, she's called Jean, presents to you, John, complaining of recurrent painful attacks in both knee joints. It goes away for a few weeks and then comes back. She's just borderline obese with a waist circumference of 90 centimetres. She says she's tired, has trouble sleeping at night. She's been feeling a bit low for the last couple of months. She's already taking ibuprofen and paracetamol from the chemist, and it's not seeming to have much effect. Well, what are you going to do about Jean?
Yeah.
She's just got osteoarthritis in the knee, hasn't she?
Certainly,
send her home.
You'd certainly think of that first, wouldn't you? That would be a very reasonable diagnosis. Female, you know, age she is. I mean, that's her current BMI. She may have been heavier. You know, there's certainly risk factors there for the more common disorder, which is always a good sort of concept to go with first. But she's been, you know, she's. I mean, does she have OA and depression? I guess that's the, you know, the thing that may explain it. It's a difficult one, but that's what general practice is about often. It's not a, you know, always clear cut, is it?
So it's easy just to send her home there, but there are other clues here as well, are there not?
Sure.
So what questions should you be asking in your 6-minute consultation just to get beyond the obvious?
Well, I guess are there other joints involved? I mean, maybe the ones that are most involved, and she's focusing on those, and obviously, you know, bring those to your attention first. If there were,
but people with OA often have narrow, painful hand joints. I mean,
yeah, that's probably going to be more in her, you know, fingers rather than say at the base of her fingers or wrists. If she, you know, volunteered.
So a distal IP joint rather than a metacarpal phalangeal joint.
Yep. You know, thinking of the sorts of classic nodes where you see that in your elderly aunt or something, but. Yeah, I mean, certainly she had other joints involved. That would certainly make you think more strongly of rheumatoid and maybe test for that at the initial consultation. Particularly she's had no response, or at least she hasn't felt she's had adequate response from taking standard medications like paracetamol and anti-inflammatories.
And of course the other clue here, Lynn, is that it's bilateral, whereas osteoarthritis is usually one side worse than the other.
Usually one side worse than the other in terms of its presentation, but certainly if you're obese, an obese female is more at risk of getting bilateral knee OA. But she's had these sort of recurrent attacks, she's got the joint swelling, and yes, she probably does have osteoarthritis and a bit of depression, but she seems to have a superimposed inflammation on that. A small percentage of osteoarthritis will be inflammatory. There could be gout crystals there could be pseudo-gout, pyrophosphate crystals, but you know, persistent inflammation, you'd be thinking other inflammatory. You'd look for psoriasis, is it a psoriatic arthritis? So there's other differentials there, but it's a slightly atypical presentation for rheumatoid. You'd look for family history. So
she's got an aunt with rheumatoid.
Okay, so there's that family connection there. So, but there is this second peak of onset of rheumatoid where you see it a bit later, late 60s, early 70s. Males are often equally affected as females. And they often have a polymyalgic onset, so looking a bit like polymyalgia rheumatica. So it can trick you sometimes. But she's already tried the anti-inflammatories, and the mild inflammation of OA would usually respond to the anti-inflammatories, and she's not responding, and she's still got inflammation. She's got these systemic things, the fatigue that the patients have.
So, Christy,
well.
This is the sort of person who gets missed, isn't it?
It is. And they're the sort of person, I guess, that when we're doing the triage, we just need to follow up a bit closer, go back and ask more questions, and they might not have indicated something to the GP, thinking it's unimportant, but in spending a little more time, you find out something else that triggers them being referred a little earlier.
Which could save quite considerable disability later on in life. I'm just going to ask another poll question now before we come back to this discussion. What access do you have to a rheumatologist? Do you have a resident local rheumatologist? Do you have a visiting rheumatologist? Do you have a telehealth clinic? You get phone support or no support at all? Be really interested to know what your answers to that are. Let's just go through some questions that are coming in. One from Anne, a nurse in Queensland. Can having a blood transfusion trigger rheumatoid?
There's certainly epidemiological evidence that people who develop rheumatoid have an increased chance of having had a blood transfusion in the past. So yes is the answer to that. But in terms of absolute risk of everyone having a rheumatoid after and transfusion, I'm not sure about the exact level, but I think you'd need a genetic tendency as well.
John, how often, a question from a physiotherapist in New South Wales, how often should patients with RA be reviewed by the general practitioner?
Again, we'll quite back to the guidelines that have been produced. You'd think at least 3 or 4 times a year would be reasonable, but it would depend on their clinical state and what other things were happening for them.
A question from a GP in South Australia: should a GP be prescribing combination therapy?
I would be a bit reluctant unless the GP was very knowledgeable and had other patients with rheumatoid arthritis for a GP to start that, because there really isn't an exact number of joints or an exact level of ESR CRP that I would always prescribe combination therapy. I would be reluctant to recommend that a GP did that. I would prefer that was done in consultation with a rheumatologist. And
is adjusting that therapy tricky?
It can be. They each have their own different side effects. Combinations of the methotrexate and slazoparin have a little bit more effect on the liver. It is a juggle in terms of which one you ramp up or down, and which ones to sort of bring in at different times. But yeah.
Christine, people often tell you things they won't tell the doctor. A GP in Nara, New South Wales, asks, many patients are reluctant to take medications such as methotrexate early in RA. How would you convince them that it's a good thing? What do you say to them when they tell you, I really don't want to take this cancer drug?
Probably the most common thing that happens when people hear they're going to take methotrexate is that they listen to everybody around them who says, it's toxic, don't take it. So the way I use education is to actually put it alongside the doses that might be used in oncology and the huge amounts and the toxicity there, and show them that the amounts you take in rheumatoid arthritis are very tiny and the toxicity is less, but also educate them about the side effects and the importance of having.
It would convince me if you told me it was less toxic than ibuprofen. That's a pretty dramatic statistic.
Yeah.
That would be fairly settling for me. Did you want to make a comment?
Well, I was just going to say, in my experience, most of the time when patients don't adhere well to their medications, it's because they have real misunderstandings about the medications that they're taking. And so I think it can be very effective just to ask the patient what their concerns are about taking them. And 9 times out of 10, you'll find that their concerns perhaps are based on misinformation or something, as you say, that they've been told by somebody else.
But you need a healthy respect for the drug, so you want them to have some concern,
Yes,
but not too much concern. You want them to have enough concern to monitor it and take it properly, but not too much concerns that then they miss out on effective therapies, because that is, and particularly in that early phase, if you said they're often confused, overwhelmed by everything else that's happening, and that's right when they can't make the decision.
And it's the same balance that you need them to have about the disease. You know, you need them to have a healthy respect for it, but not a fear of it. You know?
What question from Janet in the Greater Western Area Health Service, which I assume is New South Wales. What's the earliest diagnosed age for rheumatoid arthritis, Lynn?
Well, I think you've had the program on the juvenile idiopathic arthritis, but in that spectrum of juvenile arthritis, there are a small subset who get a rheumatoid-like illness, even as babies. But it's rash,
hepatosplenomegaly,
a different spectrum. And I guess then you see some teenage girls in particular who have classic rheumatoid arthritis, but that's a very small percentage of juvenile. But it can occur at any age, and it can start at any age later in life as well. It's unusual to see it over sort of 70 or 80 starting, but it does happen. Question from Elizabeth, who's in New South Wales. What dose of fish oil, please, specifically DHA or 2,4-G? The combination of actually the DHA and EPA combined, at least 3 grams. Yeah. Right. So you really need to look at the individual preparations to see how much. They all say there are 1,000 milligrams of fish oil, but you need to look in that and sort of work out
how much omega-3 is actually in there.
Yeah.
And it's cheaper to do it by oil than
it's
capsules.
Cheaper to do it by liquid oil, yes.
And Elizabeth also asks, is there a role for paracetamol at any stage? Yes, we say for any pain management, for any chronic pain management, paracetamol should be first line. It's a very good adjunct in that sort of first setting with paracetamol and perhaps some non-steroidals. And at any time people have a bit of a flare, sometimes in fact just a little bit of additional analgesia is all that's needed to get a little bit back control. So yes, it does have a role. So when to refer, what does the guideline say about when to refer to a rheumatologist, John? Particularly in someone like Jean's case?
Jean's case, well, she's had symptoms now for some time. So as we sort of discussed there, you'd be probably doing test and treat and refer probably in a very tight time frame, so within a week or two, depending upon the results of those initial tests.
In that sense, do you agree?
Yes, I agree. And Jean would be one that you would want to drain the knee, take that fluid off, maybe even put corticosteroid in. Unfortunately, the item number's gone now, so she'll have to pay for that. There's no Medicare item for that, but that would be therapeutic for her. She'd almost certainly get symptom relief from putting some corticosteroid in and doing that early, and then that might, in fact, mean you need to refer to the rheumatologist to do that for you.
So, Christine, what's the role of exercise, weight loss, those sorts of lifestyle interventions?
The role really comes probably after treatment's been instituted. If people are suffering, they're in a lot of pain, they feel very fatigued, then exercise is probably fairly difficult. You can talk to them about it for sure. Nutrition's important. They need good nutrition when they're unwell, well, all of the time, but particularly when they're unwell.
Yeah, but even in the setting of the inflamed joints, a lot of people think, and it's getting back to your point of the right balance, a lot of people think they shouldn't move the swollen, painful joint. But in fact, some movement is how you get rid of the toxins, and how it actually improves mobility and
Can you damage the
reduces
joint with exercise?
Very hard to damage the joint with exercise. Very hard, yeah.
So if you actually want to push it a little bit, you're not going to do yourself any harm?
You won't really do any harm. It might flare up a bit and be a bit more painful. But some range, even in acute inflammation, some gentle range of movement, some maintenance with isometric exercises, because muscles around an inflamed joint waste very quickly. And someone like Jean, sort of being older and maybe got the poor quad strength already, she doesn't do any walking, doesn't do anything, then she puts herself at risk of lots of other things. Yeah.
John, what do the guidelines say about complementary medicines?
Well, it depends. Again, we've been talking about basically fish oils as a therapy. Some people may view that as...
That's pretty mainstream. There's randomised control trial evidence here.
Well, yeah, okay, then if we take the other side around complementary medicines, outside of those, there's not really a lot that you'd say would be actually greatly helpful.
Are any harmful?
Yes, and I knew you'd ask me that, and you're much better on the name than that. Was it? I don't know, should have pronounced it.
Tripterigium or something like that.
Tripterigium wolfortii.
Oh, well done, she's practiced that one. That's good. That's good.
Yeah.
Go on, Lynn, you've probably finished that off.
I mean, I guess the key point about this is that some things, that's the particular one is a Chinese herb. The key thing for a GP is to know all the things that their patients are taking, because they're all taking something, and some of them, well, they're not harmful, but they're not particularly useful either, so they're spending their money perhaps on things.
Does glucosamine have any influence on RA?
Glucosamine probably doesn't have any role in rheumatoid arthritis. It's really the omega-3, which is fish oil, flaxseed oil, are the ones that have been proven to
and will
have
help
an
your depression at
anti-inflammatory.
the same time.
Yes, yeah, maybe.
The magic treatment.
Yeah.
Let's go to our next case study, which centres on a self-management and education programme run by Arthritis Western Australia in Perth. The course is a 6-week programme that covers a range of topics of interest to people with inflammatory or rheumatoid arthritis, their partners and support people.
We developed the rheumatoid arthritis education program because we had been running generic arthritis programs and also the Stanford chronic diseases self-management program, and it was apparent that we weren't meeting the needs of the people with inflammatory arthritis. So we did a needs assessment and asked people what they wanted, and we developed a program around that. What we do is we run a 6-week program because it's been documented that you need at least 6 weeks to try to change people's behaviour. We teach them exercises that they can do and encourage them to do so. We talk about depression and the emotional loss that comes with having a chronic disease. We talk about medications. We spend a whole session on medications, the different types of medications, and how, in which sequence they're given. And we talk about blood tests, what they mean and why they have them done. We talk about relaxation. We teach them different relaxation techniques because it's important that they, learn some relaxation and learn some stress management. We talk about osteoporosis briefly because they're much more at risk of getting osteoporosis. And we also encourage them to bring along partners and significant others because one of the issues they seem to have is problems, you know, telling people about this disease and how they cope with it.
Often you don't talk openly when you're amongst friends or family or anybody about the illness because they're sick and tired of hearing about it and you don't want to bore them. But when you are in a group like that with like-minded people and sharing the experience, you realise I'm very lucky and there are others far worse off than I am. And, you know, it's a support for each other within that group framework, which is, I found to be very valuable.
For people to get into this programme, they have to have a referral from their GP or from their rheumatologist or other specialists. They have got to be diagnosed with either rheumatoid arthritis or one of the inflammatory arthritis, for instance, psoriatic arthritis or seronegative arthritis. We do try to be absolutely sure that we get in the right sort of people that we can actually help. People have actually got to learn to manage their disease, otherwise it will manage them.
I've been going along just doing as I was told, like yes sir, no sir, 3 bags full sir. And this course has told me that either the disease can be in control or the doctor can be in control or I can be in control. And suddenly I feel tremendous because I'm learning so much.
I got a great sense of empowerment and it was to do with I am the best person to know about my disease, although I need to work within a team. So a team of health providers, but I am the leader because it is my illness, I own it, and I must manage it. And I become the expert. And that was such a liberating thought for me.
We now run this programme in some of the rural areas. We run it in Albany, we run it in Kalgoorlie and Manjimup, where we've got rheumatology nurses, and we train in other health professionals at the moment to run it in the eastern states. It's going to be run in Victoria and Queensland and New South Wales.
Because I'm so alone with it, I didn't know anybody with rheumatoid arthritis, and I felt that I was the only person walking around or limping around, the only person that takes 2 hours to do the dishes, the only person that had to give up their job. Just so many things I can't do. Cross the road. Can I cross the road and have a cup of coffee? No, I can't. I wanted to know that there are other people going through that with me. That was the primarily thing that I wanted. But now I'm here, the information's invaluable to me. It really is.
I learned more in that 6 weeks course than I had learned in the previous 28 years of my illness.
Getting people back to, perhaps some of the elderly ones, to playing bowls and just, you know, letting them know that they can play sport within their limits and that they can have a life with rheumatoid arthritis. A lot of them seem to think that their life is over.
You know, I thought, oh, you're probably going to be in a wheelchair, you know, you're not going to be able to do anything, someone's going to have to look after you, you know, but it doesn't have to be like that. And I think they teach you that in the course, that, you know, it's not, you can be your own power of your own destiny with the disease, and hopefully it doesn't have to be that difficult, you know.
I've taken up exercise programs such as the Tai Chi. I do a lot more swimming than I used to try and keep my fitness levels and everything going, but while listening to my body and getting to know my body so that I don't do too much. But it has empowered me to take up a lot of the things that previously I had thought were beyond me. One of the symptoms is depression. And for many years, I did suffer quite severely with depression, and I was actually on medication for it. But since doing the course and understanding the illness, I have found other ways of overcoming the depression, and I no longer need to take medication for the depression. So when I say empowerment, I really do mean empowerment, that I feel a lot stronger, a lot more capable, and a lot more, assertive in my own self, having the knowledge that the course brought me.
The Self-Management and Education program in Western Australia. Is it widely applicable? People have criticised these programmes, Christine, by saying, look, it's fantastic for middle-class, well-educated people who've got time to spend 6 weeks, but in fact it's not, and they're expensive, and it's not broadly applicable to the general community.
I think a lot of the generic programs are a bit like that. But certainly in my experience with this particular program, patients are actually really interested in learning more about their condition.
And what you're saying is that it's really got to be highly specific to the problem.
Well, yes, I think so. And this particular program, which you saw from Western Australia, is disease specific. People learn about their condition, they learn about all the things that go with their condition, so their drugs, their blood tests, they learn about communication, with how to work with their healthcare team.
And Louise, that sense of control can be an antidepressant in its own right.
Yeah, absolutely. And I mean, I think, you know, it's very important that you can see how people get into a vicious cycle. When they've got an illness, they feel like they can't move and they become less active and they become more depressed. And then it's harder to motivate themselves to do anything. And when they have to start, they have to take such small steps that they feel it's almost not even worthwhile. And I think programs like this, I think the real key to the success of programs is when they get people to actually change what they're doing. Because if you can get people to change what they're doing, then often you can have a much greater effect on behaviour. Some of the old education programs didn't translate the knowledge, which is absolutely essential, but probably not sufficient to affect behaviour change.
I mean, what is the role of self-management then? Because
I mean, it's actually very difficult to prove, sort of using conventional outcome measures, that it makes a difference. Very difficult to prove that. Like, how do you improve someone feeling more empowered? I mean, how do you measure empowerment? How do you measure the change? How do you prove that those people take their medications better? In fact, maybe they don't always take their medications better, they just feel better about managing their disease themselves. So by traditional outcome measures, it's hard to show that that's beneficial, and that's why they get criticised. But clearly, it's such an important part of any chronic disease. And there's certain generic elements to all chronic disease managements, but I think it is quite important that it's also tailored and specific to the particular disease and the particular drugs. And knowledge does help compliance and adherence with therapy.
Just some quick questions, because we're nearly out of time. Any role in physiotherapy for heat in rheumatoid arthritis?
Yes. Yes, I think in an inflamed joint, certainly that early morning stiffness, a warm shower, the bad hands in a warm basin of water, good old-fashioned therapy of wax therapy. So heat helps inflamed joints, as does ice in some circumstances. So that's a difficult one. It's an individual patient thing, that an acutely swollen joint, not so much hands, but an acutely swollen knee or ankle, or can respond to ice as well. So,
question from Veronica in Castlemaine in Victoria. For patients who've avoided medications such as Methotrexate for, say, 10 or 20 years and have significant disability, how much difference can biological therapies make to those people at this stage of their disease?
We've been surprised, actually, because rheumatoid, as you mentioned at the beginning, it can be a lifelong. In fact, it mostly is a lifelong disease, and people can still have quite severe exacerbations and inflammation when they appear to have sort of so-called burnt out or damaged joints. So yes, people with chronic damage are still getting a benefit from the biologics if they have ongoing inflammation.
Daniel from the University of Wollongong, I think we've got this around the wrong way. You mentioned that Methotrexate was more harmful than NSAIDs. In fact, what we said was it was less harmful than NSAIDs. I was wondering if you could elaborate on that. It's Daniel's question. Let's assume that he got it wrong, that we're talking about less harmful than NSAIDs. Yes,
this data comes from epidemiological studies because there hasn't been a randomised controlled trial that compares the two, and clearly they're working in different ways. Non-steroidals offer no benefit for disease modification, whereas Methotrexate will help put people in remission and control their disease. But in terms of the long-term effects of the GI risk and the cardiovascular risk from non-steroidals as people get older, those risks are higher than the risk of Methotrexate, and really the long-term risk of Methotrexate is liver fibrosis, but that risk appears to be quite a bit lower than we used to worry about. So people are on Methotrexate for many years, as long as that's monitored, as long as they keep their alcohol to the reasonable controlled level, 2 or less drinks and 2 alcohol-free nights a week following the guidelines. The long-term risk of Methotrexate is very low. Maybe an increased risk of skin cancer in Australia, but we have to be alert for that anyway.
Two questions from Keith from the Victorian Physiotherapy Services. Can the parvovirus trigger RA, the slap cheek syndrome?
You can get a very classic polyarthritis following a parvovirus infection. You can also get transient rheumatoid factor positivity, but mostly the polyarthritis will be gone within sort of four months. Occasionally you see people where it persists as a chronic rheumatoid arthritis after that.
And Keith also asks, how often or when should an X-ray be taken of affected joints once a diagnosis of rheumatoid is made?
The baseline, soon at the time of commencing the DMARDs, it's useful to have a baseline X-ray of your hands and feet to identify whether you have erosions or not. It's not really worth repeating that under sort of 1 to 2 years. And you would at a time perhaps when you were thinking things were in remission after a couple of years, just to make sure with your X-ray.
Question from Roy from AIM Therapy Service in New South Wales. What's the role of referral to occupational therapists and hand therapists?
They're an important part of the multidisciplinary team, that not every patient needs to see every member of the multidisciplinary team. You target it to the individuals. So people with a lot of hand inflammation, splinting can help, hand exercises can help. So an occupational therapist is very important for helping with activities of daily living, joint protection strategies. It's all part of that's where you start to have problems with access though, in terms of the access to services for a lot of the multidisciplinary. Although we say they should have it, not everyone has access to that.
And of course, totally tangentially, one shouldn't forget the feet and rheumatoid.
No, the feet are in fact sometimes to the patients the most important part of them, and that's also part of what an occupational therapist or orthotist or podiatrist can help with. Yeah.
We've already covered this, a dose of flaxseed oil and type of preparation. We're just talking here about any omega-3 preparation that gives you 3 grams a day.
Yes.
That's really what you're going to look for,
Yes.
the dose of omega-3, DHA and EPA.
Yes.
And we've already talked about hand rehab, which was a question also from AIM in New South Wales. The extent to which we should worry about the kidneys in RA.
Very unusual for the kidneys to be involved in the rheumatoid process, but it does happen that you can get a glomerulonephritis, but that's unusual, that you're thinking more of vasculitis or lupus with that. Some of the drugs can affect the kidneys, but that was really more the old-fashioned ones, the gold and the penicillamine, the ones that we use more now, and the non-steroidals. The ones that we use more now don't have that much impact on the kidneys.
It's been a very informative program. Thank you all very much. What are your takeaway messages, Louise?
Well, I think it's important just to remember that, you know, patients do need to really understand about their illness and really try and get that balance between rest and exercise, and try and, I guess, develop that healthy respect for the illness, whereby they take it sufficiently seriously, but not to the degree to which they're frightened of it or worried about the long term.
Christine?
Early diagnosis is important, and that we have people referred in quickly.
And we're talking about weeks, not months.
Yes, exactly.
Lynn?
I'd support that. Getting onto disease-modifying agents early is important, and linking in with your rheumatologist is as early as possible.
John?
RA is uncommon, but it's important to pick it up, again, as early as one can.
And get a hold of the guideline, and don't use it as a doorstop. That would be another message. Now, I hope you've enjoyed this program on the new clinical guideline on diagnosis and management of early rheumatoid arthritis. Our thanks to the Department of Health and Ageing for making the program possible, but thanks also to you in such large numbers for taking the time to attend and ask us all those questions. If you're interested in obtaining more information about the issues raised, there are a number of resources available, including links to the guideline on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send your evaluation forms to register for CBD points. I'm Norman Swan. Good night.